Um, yeah, so that's about that. So you know about endoscopic appearance of benign ulcers. They have smooth appearance and a smooth, regular and rounded edges, and a flat, smooth ulcer base filled with exudate. So it's like pale color. It's not dark color, right? So I just show you. I'm sorry, it may not be that clear. So malignant gastric ulcers are usually large. These two are malignant ulcers, and they have irregular borders that which are sort of elevated and sort of exophytic. And the base discoloration is commonly present in malignant ulcers. So those are the sort of things that you have to sort of detect, sort of suspect malignant ulcers. But of course, in benign ulcers as well, this is a benign ulcer. Sometimes you can get a red spot because there is a bleeding or a stain from the bleeding. So I'll show you pictures later. So the next question is, do we need to biopsy all the ulcers? So what do you think? I mean, practically, I mean, common sense, no. Generally, I mean, there's no clear guidelines saying not to biopsy gastric any type of gastric ulcer. But duodenal ulcers, of course, you don't have to biopsy because unless you want to check for Helicobacter, you don't have to biopsy because they have very low malignant potential. Gastric ulcers, what I would say is, if there are any suspicion, the ulcer is very large, it's more than 1 centimeter, yes, biopsy. But if the ulcer is small and if it's obviously benign, then maybe you can do a repeat endoscopy in 2 to 3 months time. And if it's still present, then you can go ahead and biopsy. So moving on to the medical therapy, because these are common things that we sort of use, and that's the thing I know. I don't know surgical therapy. You have your proton pump inhibitors, the H2 receptor antagonists, and your PCABs. So that is the new kid on the block. That is the latest sort of development in management of peptic disease or peptic ulcer disease, or any form of acid-related conditions. And then there is sucralfate, which is sucralfate is actually good for prophylaxis. It's been shown to be good for prophylaxis, ICU patients for prophylaxis of gastric ulcers, and misoprostol, which is actually a prostaglandin analog, which can be used in NSAID associated gastric ulceration. So the thing about PPIs is that they are prodrugs, right? So there are only 6 PPIs in the world. So we have 4: pantoprazole, esomeprazole, rabeprazole, and omeprazole. And then there's 2: lansoprazole and dexlansoprazole. So those are the 2 we don't have here. But I think lansoprazole is available in the Europile kit. No? That's there. That's a brand name, but I'll talk about that later. So anyway, this it's a prodrug, so it requires activation by acid. So you need to take it 30 to 60 minutes before meals, right? And it takes about 3 to 5 days for PPIs to achieve their maximum action. So sometimes people say, with 1 dose, some people respond, but technically to get the maximum acid suppression, you have to wait at least 3 days. So tell your patients, keep on taking it, even if it doesn't work with the first dose, it will work in about 3 days, right? Um, and so it can maintain an intragastric pH for more than 4 for approximately 20 hours with one dose. Yeah, whereas with a like a uh, H2 receptor antagonist, it will be about 6 to 8 hours. Right? So it's very effective. So that was the top thing until this new thing came along. New drug class. It's called a potassium competitive acid blocker. It acts on the same place, the proton pump, the hydrogen potassium ATPase pump. Okay, so it is not degraded by gastric acid. So it does not need. So if you look at all the PPIs, they have enteric coating, but these PCAPs they don't need enteric coating. and they are active drugs. So you take and immediately you get the action. Right? And the effect lasts 24 hours, and you can take with meals. You can take before meals, you can take with meals, you can take after meals. You can take it anytime. So there's Vanoprasan, that is the only sort of licensed drug at the moment, but it's very expensive, right? So just for your information, so it is sort of at the moment only used for in this gastroesophageal reflux disease. It's not basically recommended at all unless it doesn't respond to anything. Again, peptic ulcer, it's not first line, right? But in H. pylori eradication, it's now recommended as a first line treatment. That's the only place so far it has got first line approval, but it's very expensive, more expensive than your PPI. So I think it may be on the way to Sri Lanka, but may not be able to use in most of our patients. So when you do endoscopy, it is important to classify the ulcer because that decides the bleeding risk. I can actually share the pictures if you want because it's not very clear. So you get your forest classification 1A, 1B, 2A, 2B, and 2C, and forest 3, right? So if you look at forest A, 1A, there is active spurting of blood. So you may have seen there's arterial bleed and there is blood spurting from the ulcer. So obviously, very high risk, a very high risk of rebleeding as well. Forest 1B is still active bleeding, but there is oozing of blood, maybe a venous bleed, maybe a controlled arterial bleed. Forest 2A is an exposed vessel, right? There is exposed vessel, and which means there is high risk of bleeding again, but there is no bleeding at the moment. So in forest 2, there is no bleeding at the moment. Forest 2B, there is a clot, underlying clot, overlying clot. But we need to take out the clot to look at what is under that, right? So for us 2B, there is a clot. For us 2C, there is just a stain, the one I mentioned earlier. So at the base, clean base, there is a dark stain because there has been bleeding before, and because of the blood, there is a stain. And for us 3, there is nothing, just a clean base. So when you take this forest classification, that decides the risk of rebleeding, right? Of course, in forest 1A, there is no rebleeding because anyway, it's actually bleeding. So you have to do something, right? So spurting bleed, very high risk of rebleeding. Oozing bleed, about 50% of rebleeding. And in a visible vessel, about 40 to 50% risk of the patient bleeding again. Adherent clot, again 20 to 30% risk of bleeding. So this is generally where we draw the line and say this is where we need to do some form of intervention for the ulcer. If the ulcer is for us to be above, then we have to do some form of endoscopic therapy at the time of endoscopy. For us to see, there's a very low risk of rebleed and clean base, of course, lower risk. So this is the importance of the forest classification. So just so if you have a active bleeding or visible vessel, then you have to do endoscopic therapy and go for high dose PPI therapy, adherent clot. So yeah, so the adherent clot is the 2B. It's a little controversial. Some people say adherent clot, just leave it alone. Don't try to mess with it. And if the patient bleeds again, you can go again and do something. Some people say, you have to question. So depending on the patient, depending on your experience at the time and your confidence or your clinical judgment, you can decide even against endoscopic therapy. That's fine, and you can go for high dose PPI therapy. Flat pigmented spot, 2C, no endoscopic therapy, and standard PPI therapy. You can get the standard dose. Clean base, again, standard PPI therapy. So endoscopic therapy, the commonest thing available is the adrenaline injection, 1 in 10,000 or 1 in 20,000. And usually we do it, you inject about 0.5 to 2 milliliters in a 4-quadrant manner, or 3 millimeters close to the bleeding site, right? The problem is, I mean, obviously, adrenaline doesn't work forever. So it acts for a short period, but it's very good in achieving sort of stopping the bleeding in actively bleeding ulcer. It's very good in stopping the bleeding so that you can actually see what's going on. So always, so the recommendation is not to use adrenaline alone. It's basically something to improve your visibility and to get some control for a short period of time. So once you inject adrenaline, once the bleeding stops, then look at the ulcer and then decide what is the best, because you have to use some other method depending on your availability, depending on the ulcer, decide on what to do in further management. So it's not adequate to use adrenaline alone, not recommended, right? So in endoscopic therapy, the other main thing is thermal methods. So you have your contact thermal methods and non-contact thermal methods. So contact methods, you have your heater probes and you can have your diathermy and all that. So there are different types of heater probe, but the risk there is, especially at the base of a large ulcer, if you use contact, if you put too much pressure on a contact probe, if you use it for a longer period, there's a risk of perforation. Always be careful. Generally, it's not used that much now. So now what they say is to use a larger type, like 3 mm or larger probe for about 8 to 10 seconds and don't use it for longer than that. The non-contact method that you all will be, which will be available will be APC, argon plasma coagulation. But argon plasma coagulation, the problem is, as you know, we usually use it for this telangiectasia and gastric vascular ectasia, things like that. And it's not that effective for larger vessels. Sometimes, for example, for a 2A with exposed vessel, if you use argon plasma coagulation on that vessel, it will start bleeding, right? So always be careful with large vessels when you use APC because it will just drill a hole in the vessel and it will start bleeding. And endoscopic therapy, of course, the common type of clips we use is through the scope clips, which I'm sure you have seen, right? So there are the clips that you put through the scope, but there are newer methods. New method is the over the scope clip. So I'll show you a picture of that later. So basically, this is the over the scope clip. So basically, what it does is, so the clip is like it's a round thing or irregular type round thing, and you catch the edges of the ulcer with the clip, and when you apply the clip, it approximates the ends of the ulcer and closes the ulcer. It's supposed to be quite effective, and there's a recent trial. It's supposed to be quite effective. But the problem is, once you see the ulcer, you can't put, because the clipping device is like a banding device. It's outside the endoscope. So you can't do the endoscopy and do the clipping at the same time. Whereas in through the scope, you can do it at the same time. Here you have to see the ulcer, then you have to come out again and you have to apply the through the scope device and then intubate the patient again, and the patient will need sedation for this. And then you have to do it. So that is one disadvantage. Patient who is actively bleeding, if you're worried about taking the scope out and putting it again, then it may not be that useful. And of course, you may have come across this hemostatic spray. So hemostatic spray, especially if it's a diffuse bleeding, multiple ulcers, then you can use it as a short-term measure. But generally, when you use hemostatic spray, usually you have to go in again about 24 to 48 hours later and make sure that the bleeding has stopped. But it's a quite an effective thing for the short term. So it's quite common to use sequential therapy in an ulcer. So for example, this is a Forest 2B ulcer, which was initially managed with multiple through the scope clips, and then it has bled again. And this time they have applied hemospray for short-term control and gone for a interventional radiological approach. So they have done the GDA coiling embolization, and that has achieved possibility. So it's quite common to, not common, but we may have to use sequential therapy with different modalities. So basically, I don't know whether you can see it, but this is from a Japanese guideline from 2020. It's quite good. So in a peptic ulcer, if it develops a complication, perforation or stenosis, then of course you have to go for, that is one option, one reason why you need to go for surgery. In minority, you might go for conservative therapy. If it's bleeding, it's endoscopic hemostasis first. If it's successful, then you go for medical therapy. If it fails, then you can consider surgery or interventional radiology. And if in IVR fails again, uh, surgery would be the option. So bottom line is, if nothing works, then surgery is the the final ultimate option. If there is no complications, of course, you can go for medical therapy alone. So just a quick thing about this Helicobacter pylori eradication, because that's an important thing. So basically, now the theory is this clarithromycin is generally internationally they say it's very ineffective, and the clarithromycin resistance is very high. Even in the US, it's extremely high. So they don't recommend clarithromycin based regimes. Even levofloxacin based regimes they don't recommend as a first line. Sri Lanka, there are not many studies. I found one study where they have done clarithromycin, the genetic resistant the gene, and again that was found to be high, obviously, right? Because we are so much exposed to this antibiotics, so probably clarithromycin is not very effective here also, right? In the US, this is the current regime that is approved. So you have to use a PPI with bismuth, bismuth which we don't have here, and tetracycline, not doxycycline. They recommend tetracycline and metronidazole. Right? So it's a quadruple therapy, empiric. So use it for 2 weeks. And the other option is there is another combination, omeprazole or amoxicillin and rifabutin. Butin, of course, we don't have here. And then there's the other option of these new PCAPs, the vonoprazan. So basically, the theory here is you have to reduce the acidity as much as possible so that the H. pylori starts replicating. Right? When it starts replicating, only the antibiotics can start to work. So that is why we use very high dose acid suppression, because to lower the acid, so the H. pylori then starts to replicate. Right? And of course, levofloxacin based regimes and clarithromycin based regimes, they recommend only if if your local data says your Helicobacter sensitivity to clarithromycin is levofloxacin is there. So probably, although our commercially available kit has clarithromycin based treatment, probably it is not that effective. But I don't know. Even if even with the prevalence of Helicobacter, so if you look at the literature in Sri Lanka, it says anywhere between there are things there are articles that say 5%, there are articles that say 70%. So we don't really know. But I think in clinical practice, if the currently available rapid urease tests are correct, I think the incidence is quite low. It's not quite common. Yeah, so first line regimes are these rifabutin, PCAB, then the quadruple therapy, and penicillin allergy. Then you can go for these other therapies. Yeah. So finally, H. pylori infection and NCLs are the two most common factors for peptic ulcer disease. And the pathophysiology is a balance between the harmful and protective factors. And confirmation, of course, requires an endoscopic examination. PPIs are the backbone of medical therapy. PCAPs are more effective but not considered first line. And Forrest classification is very useful in deciding on endoscopic therapy. And surgery is reserved for perforation or complications and failure of endoscopic therapy in upper GI. Thank you. Are there any questions? A lot of complaints, but no questions. Audio is not working. Language working, I hope. Okay, thank you so much. You have a break after this lecture, I saw. Good. Why not come forward?
Anyway, it doesn't make not compulsory, right? Like a school class. So I'll be basically discussing uh, kind of a overview and then fundamentals of obesity surgery. Because most of the details about the operations and complications are not very much important for registrars. But if you have any questions, you can ask, but I'm not the expert in the country, but I'm doing few cases, so that must have been the reason them to ask me to do this lecture, right? So topic obviously obesity surgery. Then so there are few things that I would like to highlight. One is the concepts of obesity surgery. Uh, so as everybody correctly understand, can hear at the back, right? As correctly understand, restriction of intake is the concept of one of the concept of obesity surgery. So somehow you restrict the intake. The second thing is avoid absorption, right? So you reduce the absorption. Then most of the cases it is a combination of all, right? Combination of all. But this is the simplest view of the concept of obesity surgery. But there are misconceptions. So we have to rectify that as well, because after the operation now surgery considered as the last resort for treating obesity. And we are living in a community where they don't understand obesity as a disease. You must be very careful when handling patients with obesity, because according to them, it is not a disease. When I was working in a rural area, I did an audit about almost 10 years ago. They were coming to the surgical clinic for different reasons. And when I asked, when I given them a questionnaire and asked whether they perceive it as a no, we have selectively taken people above 35 BMI, and then they were asked whether you perceive obesity or your outlook as a disease. So 99%, so they have not perceived it as a disease. So we need to be very careful, right? Right. So the misconceptions about obesity surgery is many people believe that it is just removal of fat or even to extent of abdominoplasty. So sometimes they think that okay, I had obesity operation, or that is tummy tuck or liposuction. These are not obesity surgery. Right? It's something to do with your intestine to do the combination that we discussed. Right? Then many believe, okay, it's a simple fixing. It is not a simple fixing. I will discuss why it become very complicated process. Surgery per se may not be very complicated, and it may be another gastrointestinal operation, but then subsequent looking after the patient and then the process to achieve the goal is very complicated process. Then thirdly, many believe that you can eat the way you used to, right? So, so we have a set of uh, their own guidelines of eating. No? So then they think that they can eat the way, even among the healthcare providers now. Certain doctors who refer patients to me say that operation එක කරගත්තට පස්සේ ඕන විදිහට කන්න පුළුවන්. No, it's not the case. You have to stick to a strict diet plan. And one of the known complication after the operation, many years after the operation, is weight gain, right? So remember now, this is the last resort that you can give. This is the last weapon that you have. And then after giving, then if your patient continue to eat weight gain, then what are you going to do then? So these are the misconceptions that you need to address during your counseling sessions, right? Okay. So sometimes certain misconceptions can go up to this level also. It is something that you can wear like a fashionable band that, so some of patients might ask, okay, if your clinic gives like this is the place to do gastric banding. Now this is kind of obsolete procedure, but the patient might come and ask, can I have a blue color one or a silver color one, something like this, right? So these are the misconceptions. Right. So this is little bit about the nomenclature, but remember bariatric surgery is the most effective method of treating obesity, right? Most effective method of treating, especially resistant obesity as well as it's a sustainable remedy for obesity, right? Right. So history of obesity surgery is going even up to 10th surgery in documented history. So there was a reported case in uh, in 9th or 10th century where the king of Spain he lost his throne because he was he was too obese to function as the king. So can somebody guess what's the treatment given for him? Now putting up a purse string around the mouth, right? So that was the remedy given. So they even that time about 1000 years ago they realized that okay obesity is something to do with your mouth, right? Understand, right? But until 1950, about the last century, nothing evolved over the period of time, right? So for last 1000 years, nothing, but then last 50 years, there's reasonable improvement in treatment and care. So this is not an insult, but so even sometimes you may feel that okay, I am pressed to the wall that nothing that I can provide other than making you into house, right? Right. Okay, these are the historical procedures that they have done in last century, ileojejunal bypasses and ileocolic bypasses. So these are, now that was the era of open surgery, right? So now you can understand a morbidly obese patient undergoing open abdominal operation and a bypass, and you can assume the outcome going to be, right? So they had a lot of complications, and even the survived people had malabsorption, and therefore outcome wasn't great until the 19th uh, uh, latter part of the 19th 90th oh, about 30 years ago, right? 19th decade. And then that was the time that gastric banding and then gastric balloons, these are restrictive procedures compared to bypasses, looks bit safe. But gastric banding is not a completely safe procedure. Now we discussed that. Now on the screen right hand side you can see adjustable gastric banding where the diaphragm, the access port uh, kept underneath the epigastric fat. So you can adjust by inflating the balloon and thereby increasing the tension you put at the gastroesophageal junction. So kind of a restrictive procedure. But problem is when you keep a band around the intestine for a longer period, you get a fibrosis tissue. The moment patients start gaining weight, then you have to think of reversible procedure, the revision procedure. Then patient invariably ended up with gastrojejunal anastomosis, right? Because this is fibrous tissue and there's no other revision procedure available other than going for a esophageal bypass. So that is a disaster. So then I myself have no experience with gastric banding, but many patients I have involved with revision procedures with esophageal bypasses. So that is kind of obsolete procedure even in other countries now. Then the balloons, again, in 90s, that was a famous procedure because that's an endoscopic procedure. And you keep a space occupying device, a silicon device in the stomach, then you feel you are full, right? And then your intake is less. although it's a reversible procedure, then the cost of balloon versus the benefit that you get is not significant. So therefore, even now people are practicing as a bridging therapy, but we'll come to that later. But not a very useful, important procedure in terms of severe obesity management, right? So then by looking at the presentation, you know, the malabsorptive procedures had been very morbid and the mortality was high. So therefore, until 90, uh, so progression was very minimum. So thereafter, there were some landmark events in 1994 and 1997. Now the current practice is more towards a sleeve gastrectomy and bypasses. So we'll come to that later. But then by looking at the overall big picture, how the operation works. When you eat, it passes along the gut, and there is a process of changes, and then it is modified by brain hormones and the hypothalamus and the gut microbiota. So you all know that when the transit is less, absorption is poor. The transit is less, gut microbiota change. And gut microbiota is an evolving field where even for your mood, gut microbiota is responsible. And not only for your mood, it's for your appetite and your absorption, satiety, happiness. Most of the things are related to gut microbiota. So then people believe it's like the second brain, right? And the adipose tissues. So it's a very complex process. As surgical trainees, I don't think me as a surgeon, not unable to understand this. I hope surgical trainees also will not able to understand the deep concepts of and this hair splitting mechanisms. You don't have to know, but at least know this is very complex, not for us, like for surgeons, right? We as surgeons do not like to think too much, right? Right. Anyway, so current surgical procedures, this is the commonest procedure worldwide, the sleeve gastrectomy. On the left hand side of the screen, you can see the port placement. So this is where the umbilicus. Usually the first port is in the palmar's point. How we do is you feel the rib cage from the umbilicus, the half space. So the equidistance you put with the optical port, gain the access to the peritoneal cavity. Then your two working ports on more towards right side. Although this is in the midline, I generally go little on the right side. Then this is the retractor, the second assistant port for retraction of the omentum. And this is for liver retraction. And remember, when patient is obese, all the organs also big. And in Sri Lankan community, the problem with obesity, not that their structure is big. They have a small structure and most of the other things are add-ons. So that is fat. So then inside the abdomen, they are very small. So your ports are generally crowded, although very dispersed from outside. So you need to be very careful when handling obese patients. These are technical difficulties that you face compared to Caucasian populations or US, same Caucasian population. In Asians and especially Sri Lankan population, right? Then the technical detail, this is a technically at a glance, a simple procedure where we pass a bougie. Some of you must have seen that bougie. Generally what we use is 36 French to 38 French bougie, about your thumb size, just to calibrate the tube, gastric tube. And before that, you mobilize the greater curvature from the greater omentum. And then you pass your bougie into the duodenum by the anesthetist. And then from the pylorus, we generally keep about, that is the standard, about 5 centimeter. You know, this area is antral area, and we call antral mill, where grinding of foods take place. And then leaving about 4 to 5 centimeter from the pylorus, then you staple along the bougie to achieve kind of a Cavendish banana shape remaining stomach. Usually this is about 1/5 of the original size of the stomach. And during stapling, one must be very careful not to corkscrew, because generally stomach posterior wall is larger than the anterior wall. Unless you're careful and then hold it, there's corkscrewing of the posterior wall, which can works like a spiral, and then patient tend to have high pressure zones in the abdomen. Then getting high pressure zones, invariably now pylorus is intact, and this area, this is where one of the commonest complication is leak after the sleeve gastrectomy. The sleeve leak happens in this area. Reason, you mobilize all the greater curvature, including short gastrics. So your terminal, the most proximal part of the incision is totally rely on ascending branches of the left gastric artery, blood supply. So relatively an ischemic area. Okay, relatively ischemic area, although stomach, many tend to believe that good blood supply, right? Plus, pylorus is intact, and now stomach is, the remnant stomach is about 1/5 of the original size. So when patient produce gastric juices even without eating, and when let your patient to drink the fluid accumulate in the stomach, and then pulses pass into the duodenum. So this area becomes high pressure zone, right? High pressure zone. So then sleeve leak is one of the dreaded complications that you can think of after sleeve gastrectomy, right? So that is something that you don't want, but that is the commonest complication of sleeve gastrectomy, right? Right. So for surgical trainees, understand that sleeve leak can happen when you are counseling the patient, counsel the possibility of sleeve leak, and the chance of sleeve leak about 1 to 3%, right? 1 to 3% can ended up with ICU care, longer admission, second operation, stenting, other costly procedures, and even can cost the patient life. Remember, although they are very big, they are very fragile patients, right? Their reservoirs are very poor, especially respiratory and cardiac reservoirs are very poor, although their body is big, right? Then the second operation, what we currently practice nowadays is double bypass or the RYNG, right? RYNG, Roux-en-Y gastric bypass. These are very good for super obese patients. Here, what we do is, this is the stomach pouch, and we fashion the pouch to a smaller one, about 30 to 50 ml can accommodate after the operation. So to a size of your fist. Okay. Then the limb, this is the biliopancreatic limb, about 75 centimeter, and then the elementary limb is about another 100 to 75 centimeters. So altogether, common channel start after 150 centimeters from the jejunal anastomosis. So bypass is about 150 to 200 centimeters of proximal intestinal length, where food doesn't admix with bile and pancreatic juices. So that prevent absorption. Okay. So it's a restrictive because the pouch is very small, patient can take only little amount, and it is bypassing or facilitating malabsorption. Therefore, it's a combination. And then plus transit change, therefore, my gut microbiota and other hormonal effects also helps to overcome obesity, right? So very effective, but not free of complication. Leaks are not very serious here because unlike in sleeve gastrectomy, these are low pressure zones, right? These are not high pressure zones. These are low pressure anastomosis. So leaks, even if leak, doesn't give very much of trouble, right? Then the third operation, this is probably the commonest in South Asia. One anastomosis gastric bypass, one anastomosis gastric bypass. Many people call this mini gastric bypass, where we take a longer gastric pouch compared to RYGB, right? And then bypass about 100 to 150 centimeters of proximal intestine. But remember, this is a Billroth kind of procedure where you get bile and pancreatic juices back to the stomach. So you tend to get marginal ulcers, and you invariably get bile reflux into the stomach, right? So this is sometimes it's precancerous and then can induce cancers as a result. But more than that, patient can have bile reflux that is very troublesome, right? But weight loss and then technical expertise that required for the operation is less. But in most of the operations bypasses, we bypass about 150 centimeters of the proximal intestine to facilitate malabsorption, right? But on the other side, Asians and especially South Asians, their ileum is shorter than the Caucasians. So therefore, one must be careful about the remaining intestine to prevent stored bowel syndrome, which is not rare. And then if that happens, patient will end up with severe malabsorption, right? Now you can understand operations are not completely free of complications, and then even after long-term complications like malabsorption, and then on the other side, the weight gain, right? So it has to be a balance from as a patient, as surgical or treating team, we can only counsel, they have to be careful how they're going to utilize the tool that we have provided them. I think I have only 10 more minutes. Then the other problem with bypasses, carbohydrates, especially with carbohydrate meals, the carbohydrate rich meal immediately come to the intestine without control. Then the dumping is another problem with bypasses, right? So then the new procedures, although the word I use new, these are not very new, more than 10 years in use, preserving the pyloric sphincter here. So they do divide, I don't do this procedure, they divide at duodenum, then bypass the intestine about 150 centimeter and then anastomose the proximal ileum to the with the duodenum after making a sleeve. This picture is wrong, this is a sleeve. So therefore we call this is a sleeve plus procedures, right? Sleeve gastrectomy plus the problem of doing bypasses. Now sleeve alone not good for super obese patients. So therefore you need some significant weight loss. So therefore sleeve plus procedure, sleeve with bypass, but bypass the problem is dumping. To avoid dumping, they propose this by preserving the pylorus, right? Pyloric preserving procedure. So this is called sleeve with a bypass to prevent dumping syndrome, right? And then again, Roux-en-Y bypasses with a sleeve and with the preserved pylorus. So these are good for prevention of dumping syndrome. But again, dividing in the duodenum is something that I am a bit careful, not thinking of in recruiting my patients for procedures like this. But few cases we have done in Sri Lanka with foreign experts, right? Then secondly, all the problems that comes with sleeve gastrectomy is there because pylorus is intact, although it is a bypass. And then the high pressure zone and sleeve leaks are there even with SADI procedures like sleeve plus or biliopancreatic diversion kind of procedures, right? So these are the fundamentals of surgical procedures. Is it very boring? Huh? Right. Then the complications of obesity surgery wise, just to recap what we already discussed, leaks, especially sleeve leaks. Sleeve leaks can be even worse than WikiLeaks. Have you heard about WikiLeaks? So sleeve leak is worse than WikiLeaks for the surgeon. And then the malabsorption, sleeve gastrectomy doesn't give malabsorption. It is almost the normal integrity of the intestine. The peculiar complication of sleeve gastrectomy is sleeve leak. So in that sense, sleeve is a wonderful procedure and you have the choice of revision also. And you are restoring, you are leaving the undisturbed anatomy of the intestine. Only the size of the small change, right? Malabsorption usually with bypasses. Then the dumping again with bypasses, weight gain with all kinds of procedures unless patient utilize the tool with care, right? So this is a picture of one of my patient operated at NHSL. She had a leak. This is the leak at the esophagogastric junction on the greater curvature side. And this is after maturing. She was stented, didn't work. Pre-laparoscopy didn't work. Then had to revise. Revision is not easy. We had to get hold of a foreign surgeon to do it because we are not experienced enough to do, at least I am not experienced enough to do revision surgeries after complications, right? So that's a problem. Complete experiences of doing pediatric operations are less with us. Therefore, I myself have done only about 100 cases over the past 9 years. So the numbers are less, therefore expertise are less. Then handling complications, especially when it comes to the last stance that we have to find somebody to do it. So that is the problem. So these are the worldwide figures. This is in US. 60% of the cases managed with sleeve. And then now revision cases comes because of weight gain, understand, right? So that is also a significant, about 1/6 of the surgical population, and then bypasses about 18%, right? Then whom we need to recruit for surgery? Last year, IFSO revised guidelines. Earlier, it was BMI above 40 considered for surgery without comorbidities. Now BMI 35 and above without comorbidities, with comorbidities, even BMI 30 considered for surgery. Now, this is the last year revised guideline, but when it's come to intractable, refractory, diabetes, and even up to 27.5 BMI considered for obesity surgery in certain countries like Malaysia, right? Then certain cases I generally do not offer, and many people do not offer, although there's no clear-cut guideline. Poor compliance with diet is an absolute contraindication to offer surgery because you can't eat the way that you want. And the eating disorders, especially the habit of eating sweets, and you don't need appetite to eat sweets. toffee and chocolates and then some fizzy drinks, right? You don't need appetite. But those are calorie bombs, right? Then you start gaining weight. Then psychiatric illnesses like depressions, better not to consider. Not kind of a discrimination, but we don't want poor results and then get into the trouble. And the children below 18, I generally don't offer, but in other countries they offer surgery to teenagers, right? Because childhood obesity is becoming a problem worldwide, including Sri Lanka. But here, most of us we don't offer, but other countries they do. Right? That's why I mark in red. It is not an absolute condition. Then, as we discuss, the patient selection is the key to success. And patient has to show some commitment that I'm committed to go for operation, right? Can I take 5 minutes and finish my slides? My time is up. Is it okay to take 5 minutes? So at least patient has to prove some commitment pre-operatively. What I do is generally I replace a meal. This is now many people use in a different way. I generally replace the dinner with very low calorie meal like a drink or something like very low calorie, Optifast, some commercial preparations. Ask them not to eat for the dinner and then take a liquid meal like Optifast, and that helps me to now the cut down of weight may be about 2 to 3 kilograms, but absolutely patient is not gaining weight over that 1 month. Secondly, that clearly shows that how committed patient is. If patient can skip a meal with a drink, then that's a good thing. That is the commitment that patient shows. Then thirdly, giving Optifast or very low calorie diet helped me to cut down fatty liver, which is essential when you are retracting the liver, especially in obese patient. Sometimes this is upper abdominal operation, where like the bonnet-like liver is closing most of the stomach with especially left lobe hypertrophy and then hepatomegaly. It's very difficult to retract. The left lobe can fracture with retraction. So get some weight reduction that helps to cut down the fatty liver and then handling of liver intraoperatively. That's very important. Then the preoperative counseling, I explained them that in a rare event can even die. Right? Now we are living in an era where defensive practices is the key. And for them, most of them, obesity is not a disease. You don't know to work and then get the blame. So there's nothing to hide. Mortality is a documented known fact, right? So then the question is whether it is safe. It's safe like flying, right? This year, for past 3 months, how many flights, including some charter flights and all, at least 4 or 5 crash with some casualties, right? These things can happen, right? Not the same airline though, right? So what happened after the operation? So generally within first 2 years, that's a crucial period. Generally, most of the patients reduce weight in first 2 years. Thereafter, unless careful, from that cut down weight, sometimes if you are not very compliant, weight can start gaining, right? Say 120 kilos came to 80, 75 kilos after 2 years. And then from 75, if you are not careful, can go up 77, 80, 85. And then you catch up your weight unless your patient compliance is good. Right. So 80% of weight reduction takes place in the first 2 years. That 80% weight reduction can see when you calculate that, okay, 50 kilos need to be reduced. Out of that 50 kilos, 40 kilos will reduce in first 2 years, right? So don't take it in wrong, right? And then weight reduction prediction, say I ask, this is a standard method. just ask patient what is the most recallable lowest weight. At your 20, the most of the girls are very pretty and then good looking and very slim when they were 20. But after 2, 3 childbirth and then, it's not kind of an insultation, right? Okay, so, uh, so then in their late 30s, they gain weight and then, so the weight that they remember at the age of 20 is an adult weight, say 60 kilos. Now weight is 120, your abnormal weight is 60 kilos. Understand? So what I say is out of this abnormal weight or pathological weight, 50% can cut down over the first year. So that is the weight reduction prediction and that is the target usually that we give, right? Then the special diet, patient need to be on low calorie diet. So restriction about 1000 kilocalories. Good that if you can live with 800, bit difficult. Then with all bypasses, patient need to be on micronutrients. An immediate post-op period, generally we as surgeons manage the patient. After that, clinical nutrition guys will look after the patient, but time to time you get down and see. Right. One of my patient in 2020, sometimes that really transformed the life, right? This was in Anuradhapura. Thank you. And then many believe that they they can do whatever they want after the bypass, which is a myth, right? Okay, right. So cartoon is about. Right. Thank you very much. Any questions? Any questions? Like Dr. Udita said, no questions. Okay, thank you.
Like, hello, good morning to you all. Actually, there's originally this my representation was made scheduled at the end, but I'll do it now. And I think all of you know me. I'm Dr. Zuru from National Hospital, and the topic is upper gastrointestinal bleeding. Actually, I didn't had much time to prepare this. Actually, I was informed on last Monday or Tuesday, I think. While I was preparing for a uh, 4 day holiday trip to Vilpattu, so I couldn't make much. So actually, Dr. Chaturanga asked me to do this. Anyway, I did the half of the trip there, and I came last night. Okay, so this is from my trip. This is from Wilpath yesterday. Okay, and anyway, I thank College of Surgeons and Dr. Chaturanga for giving me this opportunity. And firstly, we will consider why we should learn about upper GI bleeding. Anyway, any bleeding surgeons should know, but particularly regard with this is one of the articles from Lancet, and here you can see whatever the cause, uh, uh, the mortality, inpatient mortality is reducing. So, if you further go for the reasons, that is the betterment of the management and the knowledge. So, this trend we have to continue, carry on, and we can further bring these things down. So, that's the main reason that we have to know. So, I will be going through brief introduction, epidemiology, etiology, pathophysiology, clinical presentation, diagnosis, and investigation management. Uh, so, upper GI bleeding. I think all of you know what is the anatomical demarcation of upper GI from lower GI. Anybody? Can anybody tell where we consider what is the cutoff point of the GI tract from upper GI and lower GI? Where? Do you know or do not know? Who does not know? Who knows then? One, yes, tell me. Huh? Sorry? Yeah. So we consider the ligament of Treitz. Okay. So above that, actually, we consider upper GI bleed because mainly due to two reasons. One is uh, most of the blood or any happening there, this will be brought as the vomiters. Secondly, up to this part, we can adequately do interventions with our endoscope, upper GI endoscope. Okay, so it's mouth to ligament of Treach. So if I earlier also I mentioned about the mortality, the incidence of bleeding here, the Asia Pacific region and Middle East region, it has very lower amount. You can see, and the Western world, rest is mainly from the Western world, including the Europe and the USA. So their bleeding is more, and this had been further examined, and it is regarded mainly due to some genetic factors and environmental factors as well. Okay, so it's multifactorial, and so with time, I mentioned earlier, with the advancement of treatment, so the GI bleeds happens due to various causes. The main reasons are firstly the varicose bleeding and secondly the ulcer bleeding. So varicose bleeding, varicose management now advanced, and advanced drugs like the carvedilol and octreotide and other drugs are coming. And since 1990s, uh, the PPIs, proton pump inhibitors, omeprazole was introduced in 1980s. So after that, there's gradual decline. Particularly in Japan, you see the Japan is always having high upper GI cancers and upper GI diseases. So they are more concerned about that. So they have been going in a big downward trend because of the management. Okay, if we take the etiology, so etiologies could be classified this is in regard with your exam point of view in various ways. Upper GI bleed, so anatomical wise. So anatomical wise, if we take the esophagus, the main the commonest reason is the esophageal varices, and other types of esophagitis, inflammatory conditions, the malignancy, and repeated vomiting causing malarious fare and ischemia can happen. The stomach, the commonest is the ulcer, because varices are not very common in the stomach, and the malignancy and other things, gastropathy, GAVE, or gastric antral bacterial etc., diulopois, those type of things, and small bowel, duodenal, duodenum, duodenal ulcer, and malignant. And sometimes directly not from the GI tract, from the biliary tract, bile can come, and it is brought about as vomitus. So we call hemobilia, and certain aortic fistula, and sometimes the fistulas with splenic artery aneurysm or any other arteries can come, and rarely the iatrogenic ones. That is the anatomical context, but for the pathological, etiological, the things with the vascular anatomy and the management. So we are dividing arterial and venous bleeding. So mainly the non-variceal bleeds are arterial. Variceal is mainly due to the venous blood comes from the venous, the portal venous circulation, and mainly cirrhosis, and other things are Budd-Chiari syndrome and splenic vein thrombosis. Here, the portal vein and other veins can get hypertensive. So there are a number of causes for arterial bleeding here. Just the presence of the disease can happen, and sometimes there can happen eroding into arterial or direct communication with the artery. So peptic ulcers can have flu like that, malarious and hemorrhagic gastritis, and any malignancy or non-malignant neoplasms, and inflammations. There are several types of inflammations, the gastritis, the eosinophilic ones, the recent ones, and pseudoaneurysms, fistulae, iatrogenic trauma, hemophilia, and pancreatitis. And if we go, I mentioned about the anatomy. So the venous bleeding mainly coming through the cavus shunting of the upper GI tract. So it can be due to the splenic vessels, splenic thrombosis, here the liver problem, portal vein problems, and any other problems. So it is important knowing that because in treatment, if you are going for interventions, we have to do the vascular intervention in one of these. And the others are in the arterial system. So knowing the areas which apply, it's important for interventional vascular interventions, radiological interventions. Going through the pathogenesis, etiopathogenesis. So mainly the variceal bleeding happens due to the hypertension, pressure increasement by occlusion of some area. I mentioned portal vein at the hepatic level or post-hepatic level at IVC. Can happen even in heart failure. So the pressure increases, backflow, and the varices happen, and varices can bleed. And main cause for the other cause is the peptic ulcer disease. Commonly it happen in H. pylori in mainly Western world, not in Sri Lanka. NSAIDs and others, they will cause imbalance of the mucosal protective mechanisms by mucus production, blood flow, epithelial cellular junctions, and prostaglandins. And more HCl and toxin selections, these will cause peptic ulcer and bleeding. I have considered malarialized tear here. So it is excessive vomiting and physical tearing. So the blood will come into stomach, esophagus, and the duodenum. If the amount of blood is little too much, it will be brought about by hematemesis, the vomiting of blood we call. And if the blood is little bit slower, but it goes towards the small intestine, large intestine, so through the anus, it is melena. And coffee ground emesis we call there is ongoing little amount of blood and it get oxidized with HCl. Okay. I'll come into that later as well. So this is again the variceal bleeding. The causes can be due to multitude, increased vascular resistance, increased magnetic circulation flow. That also happens in the cirrhotic patients. So this will increase the blood flow to the splanchnic, so more and more bleeding, and the activity, the various metabolites are formed, and the cells are and other factors are secreted. So this increase the portal pressure, and finally the varices and the variceal bleeding. Going for the other factors, so there are certain risk factors. There is genetic predisposition for various vascular and other anomalies, and for gastric cancer, so they can bleed in certain manner. And there are some other smoking and alcohol and other factors, drugs like NSAIDs, and this is LDAs, low dose aspirin, and COX-2 inhibitors. They can, I'll show you some various ways, COX inhibition and the prostaglandin inhibition, these ways, and the H. pylori infection in the antrum of the stomach, they can cause ulcers and bleeding. So likewise, they can go on the things, and particularly if the comorbid with cardiovascular, respiratory, and renal coagulopathy or multi-organ failure and increased age, this will definitely having a role as any other disease. And how do the NSAIDs and H. pylori work? So these things do work in multitude of actions. The NSAIDs have local effect on the mucosa. It will reduce the mucosal blood supply, and there will be the prostaglandins, protective prostaglandins are lost, and cause less mucus and bicarb and more acidity. And in meantime, it will cause changes in the platelet due to the COX inhibition. So the platelets are not calculated. If the bleeding happens, it is more and more. So H. pylori also, there are multitude of things, cleaning of the mucosa and reduced bicarbonate secretion and many more things. So more ulcers and more bleeding. So these are all etiologies, and particularly this study again from one American journal, and it shows when the pH is more and when the pH is less, the acidity is more, the coagulation is impaired. So if happens, it's difficult to manage due to less platelet aggregation. So the patients can come with direct effects of bleeding with some evidence of blood or altered blood coming from either GI, directly from the GI tract, as hematochezia blood from back passage, and the melena and other things I have mentioned. And other than that, constitutional symptoms like postural hypertension, or altered sensorineural due to the lack of blood supply. And I mentioned about the coffee ground. You might have seen already the coffee ground thermometers uh, like this. Okay. Uh, So management wise is one of the important slides here. So the risk stratification is the main thing is in GI bleed. So we have to get whether the patient is at very low risk or non very low risk. For that we should use uh, uh, some of the measures which are given. So usually we use Blatchford or Blatchford score. I will give these things in the later slides. So if it is 0 to 1, we can do the conservative measures and discharge. But if it is more or less more equal or more than 2, we have to admit. So the main management of GI bleeds is endoscopy. Okay, so just before the endoscopy, as any patient, we have to take the patient for resuscitation, ABC, you all know, I think. And if the hemoglobin level is less than 7, only we are giving blood. But if there are cardiovascular and other compromise, even less than 8, we can transfuse. So the ideal way with resuscitation, if stabilized, so we have to do the upper GI endoscopy within 24 hours of presentation, just after stabilization. And so if the ulcer or seen in the stomach or duodenum, clean base, there's no direct bleeding, we can discharge the patient. And if there is some stigma of hemorrhage, varices, neoplasm, dilation, or visible vessels, we can keep the patient. Okay, again, this is something with the management. Here, the blood things I have mentioned again. So, 7 and 8, the cutoff levels for transfusion. And if more than 4 units of blood are needed, we have to give other products. And platelets, if less than 50,000, have to transfuse platelets. So, if more than 4 pints were given, then next we have to go for massive transfusion protocol 111 RBC plasma and platelet. And so these patients are managed firstly, there is a resuscitation bundle, none per oral, 2 large bore cannula, and ABC, the ARV and the oxygen, and fluid boluses, and thereafter the blood to be considered. And regarding the pharmacotherapies, you have to suspect the cause. So mostly, if we are suspecting ulcers, we can give PPI. There are 2 regimes. One is the infusion regime, bolus of 80, followed up by 88 per milligram infusion, or otherwise boluses of 40 milligram BG. So if these things are not settling, we have to take to upper GI endoscopy within 24 hours. And if the stability is not gained with all these things, we can take emergency within a couple of hours to the endoscopy. And earlier days, when I was registrar, NG tube was inserted and cold saline, cold water was infused to stop the bleeding, but it is the studies have shown that it is not supportive, and sometimes it is destructive as well. So we are not using it anymore. Okay, and regarding the blood transfusion, the same thing. I am for you make it into your memory. I am mentioning these levels: 7 gram in any patient if compromised, particularly cardiovascular disease, 8 grams per deciliter. These are the cutoffs. So several times I am mentioning you should memorize hereafter for anything. Okay, regarding the pharmacology, pharmacotherapy for the cirrhosis and vascular disease, the main things are the propranolol or nadolol or carvedilol. So these will cause constriction and lessen the bleeds. And there are some trials which say other than this banning of the varices we find in our usual endoscopies, we can use octreotide and terlipressin, both the drugs for the prophylaxis. So the clinicians are advised to base the choice of individual patient factors, adverse event profiles, and cost effectiveness, that both drugs offer equivalent benefits in controlling variceal bleeding. So prophylactic, some things they use for prophylactic banding can be used these only continuing with these drugs only. Okay, so in regarding the PPI, the type of PPI usually does not matter, but that we have to use PPIs. We can use PPIs in variceal bleeding as well. So earlier I mentioned about the peptic ulcer bleeding protocols, the boluses and the infusion. These are not for peptic ulcer. These are for the after endoscopic therapy for mainly for the variceal bleeding. These patients are also benefited by PPI. So you have to memorize that PPIs are beneficial for both. Okay. Uh, and this is for the ulcer bleeding, the two regimes I mentioned earlier, the 80 milligram bolus and the uh, repeated boluses. Repeated boluses, 40 milligram, 2 to 4 times daily for 3 days. Okay. And we go for the endoscopic therapy. And every upper GI bleed who is admitted should have at least endoscopy within 24 hours. So if you are going into the stomach, through the esophagus, you will see the esophageal varices, sometimes some tears, sometimes esophagitis. Particularly, there are these days I get quite a lot of patients who have had treatment for this acne, the purulent, with doxycycline. So it causes erosive esophagitis and bleeding. I had a couple of patients last month as well. So these findings you have to get. And I just mentioned because these are not common for us. Diulophilices, these are submucosal dilated vessels which can bleed. And have you seen this gastric gave gastric antrovascular ectasia? You have seen, sometimes you don't identify it because in your endoscopy you can see things like this towards the antrum. This is gave. Okay, so these patients should have repeated endoscopy, and if there's any bleeding, the treatment of choice is argon plasma coagulation. So it is available in most of the hospitals, including NHS. So these patients should go if bleeding is there with argon plasma. And timing of the endoscopy. This study done in I think in Canada, and so this says either with or without these will benefit by early endoscopy. Okay, so and erythromycin, which is used by the gastroenterologists mainly. Surgeons don't use erythromycin as a prokinetic agent much. So, do you know the dose as a prokinetic agent we use for the frequency? What is the normal frequency dosing for erythromycin? 5 milligram, 500, 6 hourly. As a prokinetic, yes, it is 250 time interval. It's BD. Okay, so we are using it BD. So what says is when we use it, it improve visualization of upper GI endoscope at the endoscopy and improving the diagnosis and giving us more chance for the therapeutic measures. So erythromycin can be started 29 to 90 minutes. This is infusion, but we don't have infusion at the moment. 20 to 90 minutes before the endoscopy. So we can even give some erythromycin before the procedure orally. Okay, but it should be about 6 to 12 hours prior. And this is from the American College of Gastroenterology guidelines. And this is an important slide again, and this gives the endoscopic treatment modalities for peptic ulcers, bleed. So there are certain things we can do, and so if we put the endoscope, if we are going in, if we see bleed, what should we do? Okay, we go. We see that liquid blood. Do we have to do anything or not? You have to speak. Speak. Yes. We have to do what? First thing we have to do is yes. Anybody? You. Bati. Bati, you are doing endoscopy. What is the first thing? We have, so how can we see first? There's blood. We have to suck and wash it first. Okay, that is if there's fresh blood. So if there's a clot, still do we have to wash like that? Who says yes? Who says yes? Who say no? Okay. So if there's a clot, best thing is not to disturb. Okay, and let it settle with the clot, and after some time, maybe 1 week or 2 weeks, we do endoscopy and see if there is risk of bleeding. If there is, so we can treat, and the TPA and other therapies. If there is nothing there, then we can keep with the regular dose of TPA. Okay, and regarding this acute bleeders. Choice of endoscopic hemostatic therapy. There are a multitude of therapies. So the best things, these are not commonly done in Sri Lanka, is the bipolar electrocoagulation or ketocoagulation or absolute alcohol. These three are the best things. Done only in some gastroenterology medical units, but not very common. Okay, and those things are the by guidelines, ACG guidelines to 2021. So these are the best ones. Okay, and the second line things, these are available in here in our Invicta as well. Clips, argon plasma, and monopolar coagulation. These are the second line things. The evidence is low quality evidence. Okay, and if I have seen some use injections adrenaline. What will happen? There will be transient vasoconstriction, and about 1 hour or 2, it might bleed again. So if we are using adrenaline injections, there should be combination with another hemostatic modality always. Okay, and there are hemostatic therapy with hemostatic powder spray. Do you have seen your endoscopians? You ask, that is available through MSD Sri Lanka. Endoclot. Any patient comes, you can put that. There's a gadget. You can there's a vial. You can push it. Take a spray venom powder. Endoclot. So this can be used. Okay. And if this thing settled primarily and if it is recurring. So there's another thing called over the scope clip. Endoscopic clips දැකලා තියෙනවද ඔයාලා? Through the endoscope, we can with the guide wire we can with the applicator we can put the clip. So have you seen over the scope clip කියන එක දැකලා තියෙනවද? Who has seen? මාත් දැකලා නැහැ. අපි දානවා. So if it is this the endoscope, there's a clip, circular. Unfortunately, I don't have a picture. And the clip is like this, circular එකක්. එතකොට bleeder එක මෙහෙම තියෙනවනම් if you endoscope go here and suck, so mucosa will get sucked in, and we apply the clip. එතකොට clip එක යට ඇවිල්ලා mucosa එකත් එක්ක ඔක්කොම bunch එකක් විදිහට හැදෙනවා. Okay, it is available in hospital. Okay, so that is the second line therapy. If this thing has settled, if pre-bleeding happens, so we should not go back to this. It is the second line. Okay. So active bleeding of visible vessel, endoscopic therapy, adherent clot, no recommendation for against endoscopic therapy, high dose PPA. Okay. So clean base we can discharge, flat pigmented spot, nothing needed other than the PPI. Okay. So there are studies comparison of endoscopic thermal and other therapies, and this say the thermal contact devices, bipolar and heat probe are the best ones. Okay. What is this condition? Pain or the පැහැදිලිද? This is the antrum. මෙහෙම ඉරිලි විදිහට bleeders තියෙන්නේ මොකේද? What is the condition? Gave. So the treatment of therapies, organ plasma on coagulation, it's a non-contact coagulative therapy. Okay, so we are coming to our subject, that is the surgical therapy. So if endoscopic therapies are failing, then patient for next line of therapy. What is the next line? Surgery is there. Before surgery, is there anything? Before surgery, is there anything we can do? For the blood vessels, interventional radiology. So that is it. Transarterial embolization. So we can send for the if the on-call interventional people are there, we can send for them. Okay, so in patients who fail endoscopic therapy, transarterial embolization shows marked reduction in complications and hospital stay, and with no difference in mortality as compared to surgery, but have a higher rate of further bleeding. That is there. Okay, but the morbidities are very low. So this paper from this journal shows this is the conclusion, and they have achieved 100% technical success, and about 1/3 of the patient rebleeding happens, and 30-day mortality is 19%. This is they say better than doing nothing. Okay. And the surgical management. Surgical management may be multitudinal. Laparoscopic often mainly the in a very acute setting is open. So we have to undertake various things. The least may be suture ligation, and the maximum may be resection. So if we cannot control with the suture ligation or oversewing, we have to go for resection of the particular segment which is bleeding. But still, if we can find a particular artery, so if we consider the lesser curvature of the stomach, what is the main supply? Yes, left gastric. It's a left gastric. If we can find the left gastric, and if we can clamp it, and if we can see by somehow the operative endoscopy, the bleeding settles, then we can like it that because the stomach is always a very good blood supply. Okay, first is the suture ligation, and there are other methods, and finally is the resection. Okay, andrectomy, hysterectomy, and gastrectomy, and other things we have. And finally, we have special shunts for portal hypertension patients. Okay, so I mentioned there are multiple scores. You have to know these. Okay, the forest classification for the active bleeders and scores out of the main scores I have mentioned it. Procol, Baylor, and these two. So at least one you have to memorize. Okay, for the using, and most of the time they will be mentioned in the endoscopy unit as well. And scores using only the clinical. These things use endoscopic finding. They use endoscopic plus clinical. These use uh, multitude. The forest classification, there's acute hemorrhage, it is grade 1. Recent hemorrhage, some blood clot or something, it is grade 2. And without bleeding, only a lesion, it is grade 3. Okay. So management will differ. And Rockall will use the clinical non-intervention parameters mainly. This is for the rebleeding. Okay. And Glasgow Blatchford score I have just mentioned. Here it is in detail. I'll keep the presentation here. Okay. And these are outcome measurement scores. Okay. So I took okay, many things, and apart from all this, the tranexamic acid we can use in the bleeding patients. What is the dose? 1 gram is the bolus, 1 gram bolus, and sometimes we can follow up by 1 gram over 12-hour long injection. Okay, after bolus. Okay, in varicose patients we can use. Okay, in summary, so if you need the particular guidelines, there is American College of Gastroenterology, European Society of Gastroenteroscopy, and the NICE guidelines and BSG, British Society of Gastroenterology. You can Google and see it. Okay, and mainly divided into varicose and non-varicose into etiology, pathogenesis, and the management. And the management composed of resuscitation, risk stratification by spores, pharmacotherapy, pre-post endoscopy, and early endoscopy within 24 hours, and rescue therapies, radiological and surgical, you have to know, and scores and the tools for the things you have to know. Okay. Any questions you can ask from, I think, again from Rice. And okay, thank you very much. And again, this is yesterday, one of my pictures. Okay. Save करा? Huh? Save करा? I will be moving out as other lecture, nobody is here. If you have any questions, you can ask. Do you have any questions? Got so, Dr. Someone? Yes, you can. Yes, you can. That's right. Do you have any questions? Okay, thank you.
Thank you very much, sir. So we enjoyed his presentation as well as his photographs. Super talent. So a very good morning again. So I know it has been an exhausting day for you all, but just I'll keep it very simple as possible. So it's a very important topic, gastric cancer. So a little bit on the epidemiology. So it's a very common cancer in the West. Not as common in Sri Lanka, but it's about 1.2 per 100,000. So it's not worth trying screening for gastric cancer, but the consequences of gastric cancer is dangerous. So better know what the management and the importance is. So usually gastric cancer as a whole carries a uh, dismal prognosis. Usually partly because it is an aggressive cancer. Number two, it is often diagnosed at a pretty later stage. Even it may look very much resectable at times, but then when we do the investigation, staging and stuff, it always sometimes is not resectable. Even in the best of the centers in the UK, 5-year survival rate is about 18 to 20%. But in Japan, where there is more prevalence of gastric cancer, when there is a very good screening mechanism, early detection of gastric cancer at T1 stage carries a very good prognosis. Even at 5 years, it is about 80%. So about Sri Lankan data, thanks to Duminda Subasinghe sir and Amal Priyanth sir, which is the only published data in gastric cancers which we have. They have studied about 150 patients with a fairly younger population acquiring the disease, with a mainly male predominance is there, with a ratio of 2.3:1. So again, etiology, we all know H. pylori plays a role. Again, host genetics also come into play, and dietary factors also come. So about a quick word on H. pylori. It forms chronic gastritis, which causes gastric atrophy, and again intestinal metaplasia, dysplasia, and ultimately culminating in invasive cancer. So how do they present? So usually they come with weight loss, abdominal pain, and dysphagia. Sometimes if the tumor is more proximally placed, close to the GOJ. Early satiety is a very prominent feature in almost all gastric cancers, and sometimes they come with occult overt GI bleeding, hematemesis or melena, and sometimes symptomatic anemia. And sometimes you find an epigastric mass, which is often considered a poor prognostic factor, because if it is palpable, it has to be a pretty advanced tumor. And if they come with metastatic symptoms, that often is bad news. However, it's worth to know that there are paraneoplastic presentations as well. Patients can have seborrheic keratosis, acanthosis nigricans, and there are certain other microangiopathic hemolytic anemia and stuff, which I don't think we should know in detail. So about this classification method, there are lots of various types of classification methods. Bowman classification, which is the macroscopic appearance of the lesion. And there is another classification called Paris endoscopic classification. And another type of classification would be a histological classification, whether intestinal type or diffuse type, or the WHO classification, which it's talking a lot about vestibular, papillary, poorly cohesive, which is not a surgeon-friendly area to anyway. So what is important to us is the TNM staging. So how do we stage? Tumor, node, and metastasis. When it comes to TNM, T1 to T4 is there. So most important points I have highlighted here. These are one that mentioned as T1A, which is the tumor invades the lamina propria of the muscularis mucosa without involving the submucosa, is the cutoff that we take for endotherapy. Okay, and the T4A here, the later stage, advanced stage, which says the tumor invades the serosa, that is the visceral peritoneum, is the cutoff that we take for resectable disease. However, having said that, T4B disease, which says tumor invades adjacent structures, it is some structures can be resected, which is again conditions apply. I'll come to that later. So about nodes here, depending on the number of nodes that are involved with the cancer, we categorize into N1, N2, and N3. However, this is pre-operatively done as well as post-operatively done, but more accurately done post-operatively than pre-operatively, where the minimum number of lymph node harvest should be 15 lymph nodes minimum, which means the higher the number, better the nodal status is. About the metastasis, if there is distant metastasis, we take it as M1. About T staging here, so you can see if it invades the lamina propria or the muscularis mucosa, it's T1A. If it involves the submucosa, which is here, it is T1B. But endotherapy is only applicable to this T1A. But if you take the depth of involvement of various T stages, it is self-explanatory. So how do you stage? So as we all know, we do a CCT with oral contrast with chest, abdomen, and pelvis. Why do we do pelvis? I hope you know the answer. Right. So yeah, correct. So that is the answer. So when you take the CT, contrast enhanced CT, it has a very good accuracy for T staging. And for N staging also, it has a fairly good accuracy. But however, for liver mets, it is not a good tool. But if you see liver lesions, yes. But what is good for liver lesions is MRI. With a liver specific contrast enhanced MRI with the DWI imaging. How about PET-CT? What is the role of PET-CT? PET-CT is to detect the occult metastasis. But do we have it really? Of course no. And a quick word on EUS. EUS is good to detect T1 from T2 disease, and sometimes it is not a very good tool in detecting the regional lymph nodes further away from the stomach. So staging laparoscopy is a thing that we all can do, and it's easy to do. A quick general anesthesia, put the scope in, and see what are we going to see. We can detect occult metastasis, which sometimes the PET-CT would not have detected. And if there is free fluid, you can take free fluids for cytology. Even if there isn't free fluid, you can get peritoneal washings for cytology. If it becomes positive, that is considered M1 disease. In the meantime, if there are any surface lesions, liver lesions, we can detect that. Also, sometimes peritoneal disease or mental metastasis may not have been detected in the PET-CT, which we can directly see. So, but the limitations, we all know deep-seated liver lesions may not be seen, and sometimes you might find it difficult to see the lymph nodes, perigastric lymph nodes as well. So, who should get a staging laparoscopy? Basically, if the patient is up for curative intent pathway, better to do a baseline staging laparoscopy to see if the patient is actually in the curative pathway. That is to say, there is no M1 disease. Okay. So what is early gastric cancer? What is the definition of early gastric? So early gastric cancer is an adenocarcinoma that is restricted to mucosa or submucosa, irrespective of lymph node status. So here, if you can see, it is restricted to mucosa or submucosa. But earlier in the slides, I told you, if it is confined to the mucosa, we take up endoscopic therapy. But even if it invades submucosa, it is considered early gastric cancer, regardless of the lymph node status. But how often do you come across something like this? It's almost a it's never had we have never come across such a case, but it is very common in screening is there in Japan, countries where there is good screening mechanisms. So sometimes if you do endoscopy for something else, if they find a lesion, that is of course a possibility. So, but for us to have an early gastric cancer diagnosis, we should do a proper endoscopy. What is the time that you take for an upper GI endoscopy? Usually 5 minutes. Yeah. So that is the whole time for scoping in and scoping out, right? But for us to detect early gastric cancer, we should have a good view of the stomach. Before having a good view of the stomach, we should inflate the stomach fully and wash the stomach. There are food debris or bile stains, all that should be washed out, and so that we can see a good view of the stomach. And we have to adequately insufflate the stomach. And there is called a 3S systematic screening of the stomach, which has to be done for at least 7 minutes, right? And we can certainly use image enhancement like digital chromoscopy like NBI and all that. So if there are any abnormal mucosal areas, we can detect. And of course, if you detect anything, you have to photo document it for further reference, future reference. However, AI is replacing most jobs. And today morning I saw Bill Gates was telling us the medicine is going to be replaced with AI pretty soon. And again, here we are. Artificial intelligence is replacing cancer detection. There is a commercially available product from Fuji, which can detect early gastric cancer pretty accurately. So, what are the things that you see in the gastric cancer, early gastric cancer? Of course, if there is a fungating ulcer, we see it's pretty easy for us to diagnose a gastric cancer. But what would suggest an early gastric cancer if you don't see much of a lesion? So there can be differences in color of the mucosa, loss of vascularity. There can be mucosal irregularities, or the fold pattern may be abnormal. So if you see a lesion, you have to measure at the size of the lesion, location, documentation is important. Margins, whether there are clear defined margins, you can see this lesion has a very clear margin, ulcerated or not, and if it is close to the GOJ, how far it is from the GOJ or how close it is to the GOJ. And there are various classification methods called Paris classification and VS classification. So if you know that, better to document that as well. So let's say you detect a lesion with early gastric cancer. You suspect that it is an early gastric cancer. You take a biopsy, yes, confirmatory, and you do an endoscopic ultrasound and cross-sectional imaging to look for the depth of penetration and the extent of the disease. That is to localize the lesion as well as stage the disease. If you say if there are no lymph nodes and if the lesion meets the criteria for endoscopic resection, you go for EMR or ESD. But if you detect lymph nodes or if it doesn't fit the criteria, you go for surgery. Right? So, what are the criteria that we have laid down, or the guidelines says it has to be a well or moderately differentiated carcinoma. It has to be without ulceration, and there has to be clear margins. The margin should be lateral as well as deep. The margin should be clear, and it has to be T1A without any submucosal involvement, and it has to be less than 2 centimeters. But the latest guideline says up to 3 you can try, but that again is not, it's subject to debate. There should not be any lymph nodes or any lymphovascular invasion. And it has to be an intestinal type. If it is a diffuse type, you don't find clear margin. Okay. So what are the techniques that we have? EMR and ESD. What is EMR? Endoscopic mucosal resection, and ESD is endoscopic submucosal dissection. Usually ESD requires a lot of technical expertise and we need instruments. But EMR is not as technically demanding as ESD, but however, it carries in terms of recurrence, ESD carries a better prognosis. So, what are resectable gastric cancers? Okay, so the chart here shows stages of the gastric cancer with relevant T stage and N stage up to stage 3. It is resectable. Okay, whether you give neoadjuvant chemotherapy or whether you go for upfront surgery is an MDT decision. But all these are considered resectable gastric without any M1 disease. Okay. So before we dive into the topic of surgery and the resectability and all that, let me introduce these lymph node stations when it comes to gastric cancer. Okay, we divide into 4 groups, basically 3 groups: N1, N2, and N3, N4. Okay, what are N1 nodes? N1 nodes are the ones that lie around the stomach. What are those? Right paracardial, left paracardial, lesser curvature, greater curvature, suprapyloric, infrapyloric. Okay, and the next one is N2 station. These nodes lie along named arteries. Okay, left gastric artery, which is here, common hepatic artery, which is here, celiac trunk, splenic hilum, and splenic artery. So all these are N2 station. And N3 and N4, that is in the hepatoduodenal ligament, that is the hilar lymph nodes, we call it hilar lymph nodes, right? And posterior to the pancreatic bed, superior mesenteric vessels, middle colic vessels, and parotid. You can see the stations go further and further away from the stomach, right? So what next is, we should know little bit of terminology when it comes to gastric cancer management, right? So gastrectomy, if you take gastrectomy, the margin that we take for any gastric cancer would be, if it is invasive gastric cancer, it has to be about more than 4 centimeters. Anything more than is good, anything less than is not good. Why? Invasive gastric cancer can spread to submucosa already. So there is a submucosal spread. There can be. So the chances of it having a margin positivity is high if you don't take adequate margin. So what are the options that we have? Total gastrectomy, distal gastrectomy. And there is a new entity, or some surgeons have practiced, called proximal gastrectomy. Right. Next is, I told you these lymph node stations, N1, N2, N3, and N4, that we have already discussed. And lymph node dissections, we call it D1 dissection, D2 dissection, and D3 dissection. Okay, next, what is D1 dissection? We take lymph nodes in the N1 station only. That is the paragastric nodes. If you take the gastrohepatic or the pars flaccida and that ligament and the gastrocolic omentum out, that would do for N1 dissection, right? But if it is D2 dissection, it has to be N1 plus N2. For this, you need to dig into the lymph node stations and harvest those nodes. What are those nodes? We have already discussed. D3 is taking away all the lymph nodes, even up to the parotid gland. Problem with D2 is, I told you, it's a we dissect lymph nodes along the splenic hilum, splenic artery, all that is dissected. So there is a chance that you might have to take the spleen out. So this carries a much higher morbidity than N1 or D1 dissection. But without the other organ resections, this N1, N2 or the D2 resection is the standard of care. Okay, that is the standard of care. Okay, right. Now, what do we have as surgical options for the stomach? Right. So D2 dissection, that is total or distal gastrectomy with N1, N2 lymph node dissection. That is the standard of care. Okay. What are non-standard options? We have modified surgery, like anything less than this, what is described is modified surgery. It could be a segmental dissection, or anything less than D2 dissection is a modified surgery. What is extended surgery? Combined organ resection or anything more than N2 lymphadenectomy. That is to go for parotid lymph node sampling or something like that. So that is extended surgery. So how about proximal gastrectomy? Take the proximal part of the stomach out and you anastomose the rest of the stomach to the esophagus. But this is not very much recommended because it carries a higher rate of reflux and and you leave much of the stomach out. So it's not it doesn't not give good quality of life as you would with other options. But if a patient is elderly, if you can't tolerate a major resection, this would be an easier option, even sometimes for GOJ cancer. Okay, so this is about distal gastrectomy and total gastrectomy. So, what are the reconstructive options that we have? So, this part is out, where the esophagus and the duodenum is there. So, the reconstruction options that we take up should improve the quality of life of the patient, and it should reduce complication and to maintain the physiology. So, the maintaining physiology would be mostly achieved with this duodenal tube, which is intact. But usually surgeons prefer to do a Roux-en-Y reconstruction with the jejunal loop here, with or without a pouch. But the duodenal transition tract will be intact with the jejunal interposition like this, with or without a pouch. So those are the recommended options. Here it's a very more clear picture here. Okay. Right. How about neoadjuvant chemotherapy? So I don't think I should talk a lot on this. We all know that it has been proven to have overall survival and progression-free survival with neoadjuvant chemotherapy. But the problem is neoadjuvant chemotherapy is based on pre-operative imaging data only, not with actual data. Unless we do a diagnostic laparoscopy, staging laparoscopy, and do a lymph node staging, we don't know. So sometimes it can be underdiagnosed or overdiagnosed and might be overtreating or undertreating. So again, subject to debate. Right. So what are non-resectable gastric cancers? Can be locally advanced. It could be disease infiltrating the root of the mesentery, or invasion or encasement of major vascular structures, except the splenic vein. So non-regional distant metastasis nodes, parotid lymph nodes, or Virchow's node. All these are considered non-resectable. Distant metastasis, if it had spread to liver, lung, bone, obviously we exclude the patient from curative intent. But I told you diagnostic staging laparoscopy, if there is peritoneal seeding or even if for a positive peritoneal machines taken as M1 disease. What options do we have? You can do a palliative distal gastrectomy if there is bleeding or obstruction. But we have taken the decision for palliation considering something serious. So doing a major resection might not be the best option, because the patient will be so cachectic, weak, nutritionally depleted. So in that option, a bypass surgery would be a better option, like gastrojejunostomy. Okay, so sometimes gastrojejunostomy might also fail, in which case you might have to do a PD jejunostomy and a venting gastrostomy. So these are the palliative options. But we can, if the patient is bleeding, we can try endoscopic therapies or interventional radiology help. So there is some role of chemotherapy and targeted therapy. So a little bit about this Siebert classification. So we should know this lens, which we can classify it as Siebert 1, Siebert 2, Siebert 3. So essentially we classify Siebert 3 as gastric cancer, Siebert 1 as clearly an esophageal cancer. The area of debate would be here in the Siebert 2 region. So where depending on the esophageal involvement, you can treat as such. Okay. Right. So as a conclusion, usually it is late diagnosis, and at the time of diagnosis, the chances of them having more advanced disease is more than 50%. So very minimum number of patients will undergo curative intent surgery, and we don't have screening for gastric cancer here, which is not feasible considering the lower prevalence. And even again, those who you think will benefit from surgery should be carefully selected. Okay, thank you. So, any questions? I think the next is again a case discussion, which is on gastric cancer. So shall we go discuss and then we'll discuss because a lot of the questions will be answered there. Okay. Okay, so this is a case we have already discussed. Okay, so it has to be an interactive discussion. So I need active participation from your right. So this is the patient's history. The 60-year-old female, ASA1, BMI is more than 30. Investigated for left hypochondrial pain and loss of appetite. Examination was basically normal apart from high BMI. How would you investigate this? So since we are in discussing stomach today, don't just think about stomach, just think about other diagnoses as well. What do you think? Shan, how would you investigate this patient? Now this patient comes to you in the clinic. You are the registrar, you see the patient. How would you investigate? Yeah, good. What are your differential diagnoses? Hmm. Yeah, or he's considering gastric and pancreatic CA. So why don't you think about other diagnoses? Ganit, what do you think? Yeah, okay. He would think of a lower respiratory tract infection. What do you think? Yeah, could be spleen, anything. No? So how would you investigate this patient? Now, yes, you have taken a good detailed history and you have examined the patient. Now, how do you investigate this patient? Another one, what investigation would you do? Yeah, okay. What are the basic investigations you would like to do? Now, when you tell blood, this is the exam point of view. When you tell blood count, what specifically are you going to look for? Yeah, hemoglobin level. Why? What is the importance of hemoglobin? Yeah, he's an obese patient, complains of loss of appetite. So, pardon? Yes, any chronic illnesses. So, anemia is your concern. Okay, what else? Hmm. So, what in the liver function test would you be worried about in this patient? Or liver full report, full liver profile? Albumin, yes. Why albumin is important? Hmm? Yeah, in nutrition, basically nutrition. And if you are going to carry out a surgery, it again has a importance. What else? How about the bilirubins and ALP, gamma GT? What information can you gather from them? Though the patient, yes, correct. The patient does not complain of jaundice. Huh? Yes, loss of appetite is there. No, there can be something there in that region. Still we have not imaged. So still there can be something going on. Okay. So what imaging modality would you choose? You are in the clinic now. Yeah, we would do an ultrasound scan. That would be the same thing to do rather than asking for a CT scan, because the radiologist will come and yeah, correct. So yeah, in the ultrasound scan, what information would you like to know? I forgot your name. Kanidu, what's your name? What? Deshan. Okay, Deshan. What information would you like to know? Yeah, yeah, exactly. Yeah. So he's thinking of, because this is, I'm repeating your phrase because these are the benefit of those who are joined online. Okay. So he's telling his patient has loss of appetite and he would like to consider anything sinister in stomach, pancreas or liver. Yeah. What conditions are you worried about? Yeah, look for malignancy. Yes, yes. Yeah. So you mentioned a few sinister diagnoses here. So what are the things you can detect in ultrasound? What information can you gather? It's very limited, no? Yeah. If you see a focal lesion, yes, you would be interested. But what other investigation can you consider? Serum amylase. Yeah, okay. Would you consider an upper GI endoscopy? Huh? Yeah. Those who say yes, yeah. Those who say no. But she didn't have typical features of gastric CA, you know. But still, you would not, you should not miss a gastric CA. So, upper GI endoscopy was done. Okay. So these are the findings. Again, ultrasound didn't pick any problem. So, what before that? Can you tell me? Now you did an upper GI endoscopy. What information would you document? You see a gastric lesion. How would you write your report? Yes, I'm sure you all are doing upper GI endoscopies. You would have come across gastric lesions, even cancers, sometimes benign ulcers. How do you document? Because I mentioned a few things in the previous lecture also. How far you have reached? That is number one. Number two, the healthiness or the normal nature of the structures that you have visualized. Always document. And if you see a lesion, you know whether it's lesser curvature or greater curvature, what is the size of the lesion, what is the morphology of the lesion, whether it's ulcerated or not, and whether there is any active bleeding, okay, whether there are any dysplastic changes around, right? There can be a very clear defined lesion, but if you look carefully, if you scope carefully, you might see some unhealthy areas surrounding. What does that mean? What information would you does it give you? You see a cancer, but the surrounding mucosa looks unhealthy. Isha? Yes, it is spreading submucosally. So it can be a diffuse type, right? It can be an intestinal type or a diffuse type. That again should be, you can suspect query intestinal type. And what else? Distensibility of the stomach. No? Why is it important? Pardon? Linitis plastica. Okay. So linitis plastica means the stomach might not be distensible. No, it's called the leather bottle stomach. No, right. So how do you detect that? Sometimes you scope in, you see a nice tube-like structure, but when you come out, how do you detect that? Usually, when do we detect that? usually when we come out of the pylorus, we look at the area beyond the incisura. You look around and you come, look for any pathology there. But when you do a J maneuver or retroflex the scope, if it is a poorly distensible stomach, you might find it difficult to distend the stomach. Might not be easy for you to come back to the fundus and see. Okay. Okay. Now in this patient, GOJ was at 40, fundus was normal, and there was a malignant looking ulcer, the lesser curvature. It was about 5 centimeters in size, clear demarcated ulcer. I'm sure, I'm sorry, the photos are not very clear. Antrum was normal, pylorus was normal, duodenum. So it's a mid-gastric tumor. Okay, usually we find a distal gastric tumor, right? But it's a mid-gastric tumor. This is a real case scenario I'm discussing. Okay? So histology comes as poorly differentiated invasive adenocarcinoma. Okay, we're starting off with on a bad foot now, right? Okay, how do you stage this? But yeah, you said yes. CECT might not be the best answer you can give as a postgraduate training. No? Yeah, but yeah, contrast enhance CT with oral contrast in chest, abdomen, pelvis region cover. Okay. So what information can you gather from that? I'm sorry, I know very few names here, so it will be hot. Sandharvan, what do you think? Huh? You assess the T and M. So in T, you assess the tumor location, the tumor depth, and tumor extent. Okay, whether the primary tumor is going beyond the serosal layer, that is invading the surrounding structure. Okay, in nodal status, and M metastasis. What are the M metastatic areas that you are worried about that you can see in the CT? Pardon? Yeah, what are those ones? Because in the exam, when you get a gastric CA or any cancer patient, you will do a CT, I will do a CT and stage the patient to if you can give the answer. I will do a CT, I will look for this list එකක් දෙන එක වඩා වටිනවා. මොනවද බලන්නේ? liver වෙන මොනවද? pancreas එකේ mets එනවද? pancreas එකේ direct invasion එකක් එන්න පුළුවන්. mets එන්නේ නැහැ සාමාන්‍යයෙන්. So ඒක T stage එකේ T4B වෙනවා එතකොට. Understand? pancreas එකට ඇලිලා තියෙන්න පුළුවන්. invade වෙලා තියෙන්න පුළුවන් primary tumor එක. So that becomes T4B disease. Okay? But distant mets කියලා liver, correct. Ovaries, yes, it's an adenocarcinoma. So ovaries, what do you call that condition? What do you call those tumors? Krukenberg tumors. That is one of the reasons why we should do a pelvic CT. Anything else? Any other metastatic regions? Lungs, very good. Anything else? Peritoneum, free fluids, balanapula, paraaortic lymph nodes, hilar lymph nodes. All those are considered non-regional lymph nodes. So yes, vascular invasion. SM එක කොහොමද සීලේක ඇක්සිස් එක කොහොමද ඒ ටිකත් බලන්න ඕනේ. So information ටික ඔක්කොම කියන්න පුළුවන්. හරි? So this CD shows lesser curvature gastric lesion, organ confined disease with some regional lymph node enlargement. Liver peritoneum was normal. Okay, what is the way forward? No mention about T stage, no mention about N stage. So sometimes we come across reports like this also, no? How do you tackle that problem? How do you take matters? Are you going to take matters into your hand, or are you going to share the business with others? Huh? Yeah, what is the answer? What is the magic word which oftentimes you forget in the exam? MDT, yes. So we have to have a multidisciplinary meeting to know what to do or to discuss what to do, what is best for the patient. Okay. Yeah. Okay. So sorry for this slide which comes late. HP 6.8. What does that mean? You may be bleeding, no? You optimize that, and next you took the patient to MDT. So MDT, they decided upon upfront surgery. Okay. So laparoscopic assisted total gastrectomy plus D2 lymphadenectomy plus omenectomy was planned. Okay. Now tell me how I'm going to prepare this patient for the test. Those who are online can answer. Yeah. How do you prepare? How would you prepare the patient? Is she nutritionally depleted like all other gastric cancer patients? No. He has a BMI of more than 30, but that carries another problem there. So you might have to attend to a nutrition, which is over nutrition, right? Okay. So an exam you discussed about your patient, not a template patient or a textbook patient. So discuss about your patient. Okay. So I was happy that during the Maharagama mock examination, one candidate was talking specifically about his patient. Okay, it was very good, and it showed that he was living in his patient's life. Patient real problems ටික බලාගෙන ඒකත් එක්කම කතා කරනවා. So that's good. So that is what you should do in the exam. Right? So her nutrition is over nutrition. You have to have that also addressed. Right? What is anemia? Correct. Right? What else? What other problems do you have you come across? She's on the 50s age, obese. What other problems can she have? Yeah, she could have cardiorespiratory issues, which may not have been evaluated before. So we might have to evaluate all these things, right? So obstructive sleep apnea එකක් තියෙන්න පුළුවන් මෙයාට. This is I'm talking about a atypical patient කෙනෙක් මෙයා. Right? So all these things should be addressed in the preoperative period, right? Right. So would you do a staging laparoscopy or a PET CT in this patient before surgery? Those who say staging laparoscopy can raise your hands. Those who say PET CT. None. Those who say both. No. He says yes. Yeah, ideally yes. You can do both. Yes. In a Sri Lankan context, PET is almost, if you ask for a date, never you patient will be metastatic by the time he or she gets the PET done. No? Because that is the availability that we have, the info availability. But staging laparoscopy on the other hand can be done. When would you do it? Do you take the patient up as on a separate date, or would you do it on the table prior to the resection? On the table would be a better option, but you might have booked that patient only. Metastatic then you might lose the whole theater day. So staging laparoscopy on a separate day would take maybe maximum 1 hour, 30 minutes to 1 hour. So might not be a major problem if you put a scope in and come out. So on a different day prior to the surgery would be a better option. So different centers have different practices. So this is the center I was trained. So staging laparoscopy prior to the surgery or prior to chemotherapy would be a better option. Okay. Right. So if the patient was taken up for surgery and staging laparoscopy was done. But how would you position the patient? Now it's a laparoscopic resection, remember. Otherwise, if it's a gastrectomy patient, how would you place or esophagectomy patient, abdominal access esophagectomy, transhiatal esophagectomy, let's say, or gastrectomy for that matter. Pardon? Yeah, supine. Yes, supine. But as it's laparoscopical, the surgeon might come in between the legs. So the legs should be abducted. Okay. Which hand would you give to the anesthetic? Because of course, because I'm still a trainee, I'm currently undergoing colorectal training in Ragam. What I tell my house officers and registrars is, on the previous day we put a cannula anyway to hide it. So over hitala balla දාන්න. Because sometimes very often ಈ table එකට ගියාම අර ටක් කරන hand එකට තමයි cannula එක තියෙන්නේ. ඒකට එක්ක extension එකක් දාන්න නැත්නම් අනිත් පැත්තට. Unnecessary tricks. So if you can plan your surgery, so like it's an open gastrectomy නම් දැන් කොහෙන්ද එන්න ඕනන්නේ? කොහෙන්ද retraction එකක් වැඩිපුර අවශ්‍ය වෙන්නේ? ඒක හිතලා බලලා තමයි අතට cannula එක දාන්නේ. දැන් lap call එකක් ගන්න. Forget about gastrectomy. It's more laparoscopic cholecystectomy. Which hand would you touch? Which hand would you keep on by the side of the patient? Left, no? So right hand should be cannulated. So again, you plan your surgery before. Okay. So supine with both arms abducted, restrained with a belt, hips abducted. Okay. Right. So open Hassan entry was taken and 12 millimeters pneumoperitoneum and two other ports, 10 millimeter ports and 3 5 millimeter ports, which is of course technical and varies from surgeon to surgeon, the placement as well as the number of ports, but this is just a general guide. Peritoneal survey was done, all good, where we looked at the tumor not extending to serosa. It was the mobile stomach. What does that mean? Stomach was very mobile, which means it does not invade into surrounding structures. Lymph nodes were not much involved. Liver was void of any metastasis. Peritoneum was normal without any fluid. Okay, that was great. Okay, so I'll show you a video. I have a very interesting video to show you. We'll skip this slide for the time being. And once the surgery has been done, the mobilization, everything was done. Distal division was done with a endo-GI stapler. Okay, that is the pyloric D1 junction was divided with a endo-GI stapler. The rest of it is completely mobilized laparoscopically. All the lymph node stations were taken on block with a momentum, and then we converted to upper midline mini laparotomy, and stomach was divided from the distal esophagus. We did a 21 millimeter circular staple anastomosis with a Roux-en-Y with a jejunal pouch, which is the neo stomach, and that was created again with 100 millimeter linear staplers, and anastomosis done with 21 millimeter circular staple. Might sound very technical to you, but I'll show you how it was done. Okay. Right. So shall we watch this video? Okay. So that will show you how things are. Okay. Now this is, of course, we are dividing the transverse colon from the omentum. So the plan was to take the omentum of with the specimen. So the transverse colon was mobilized and with the use of ultrasonic dissectors. Okay. So when you divide the transverse, the gastrocolic omentum, you might enter the lesser side, and you might go behind the stomach. Okay, that is in the lesser side. So this, of course, the speed was increased to, I think, 3x or 2x. I can't remember. This was done was one year ago. Right? So now we are dividing the short gastrics. You can see the screen there. Okay. Short gauge strips are being divided. Okay. Then lever retractor was placed, lifting the left lobe of the lever, and there you can see the past flaccid is divided. Okay, and now the dissection is kept closer to the liver than the stomach. That is to say, that is done because to retrieve as many lymph nodes as possible. Okay, now this is the right truss of the diaphragm. Truss is separated from the esophagus. So this is standard dissection for the esophageal mobilization, for esophagectomy, for hiatus hernia, for Ehlers cardiomyotomy. Okay, so this is on the other side, left side dissection. Okay, so now the esophagus is gradually being mobilized, and now starts the lymph node dissection. Okay, so this is the hepatoduodenal ligament. You can see a lymph node there. Okay, which is often called the hepatic artery node के लिए genu node के लिए what नाम? So ultrasonic dissectors is a handy tool to do this kind of dissections. So this is lymphadenectomy. Okay. Now you see the left gastric artery being tainted. Okay. With the assistance retractor here lifting the stomach up, you can see the left gastric is tainted. I hope the video is clear to you. Okay. All the fatty fibrous tissue is taken. Okay. So there you can see the gastric vessel there. You can see how the harmonic scalpel is, used here, bit by bit, with the active blade is used to dissect the planes. Okay, you can see now you can see the common hepatic artery is coming to the wheel. What you see there is the hepatic artery. This is the left gastric artery. Common hepatic is here. Okay. That is the common hepatic artery here, and the hepatic artery going there. The GDA will be somewhere here. Gastroduodenal artery. So that is the left gastric. Again, some more nodal dissections are being made out. Now the left gastric is divided at the division of bifurcation of the celiac trunk. Okay. Now we are trying to find out the splenic artery. Okay. further mobilization of the hiatus to have more access. It is again hiatal mobilization. Furthermore, those are the hilar lymph nodes, clinic hilar nodes, D2. So you might start seeing the clinic artery here. What you see there is the splenic artery here. Okay. So that is the DJ flexure, DJ junction. So we located the row loop division, point of division. So we created a window. And this is the pylorus that is being divided using endo-GI state. Okay. So rest of the surgery is open, right? Okay. So this is how we anastomosed. We created a pouch, jejunal pouch with a rolling using endo-GI staplers, and the circular stapler was passed across to the tip where the anvil was placed. Okay. But unlike the rectum, the spike which comes out and the push that they give will tear the jejunum apart. For that, we used a purse string again. Purse string it stays in position, so we could anastomose nicely. So this was the specimen. This is the esophageal end. This is the pyloric end. The whole lymph nodes were out along with the omentum. Okay. Now this is the histology. Okay. G2 adenocarcinoma. There comes another word, Lauren classification. What does that mean? Lauren is a histological classification where they say it's a diffuse variety or intestinal variety, and it has a prognostic value as well. So lymphovascular invasion, perineural invasion were not present. Margins were clear except serosal surface. So which means what is the T stage? T4A. Okay. Right. But reported as T2. Okay. Lymph nodes, 25 lymph nodes were there, and none of the lymph nodes were positive. Is good news. Okay. Now, what is the place for open surgery and laparoscopy? Can you answer this question? So these are the questions that I'm going to ask you and you're going to answer. That is the role of staging laparoscopy, D2 lymphadenectomy, what are the reconstruction options, jejunal pouch, bursectomy, PD jejunostomy. So these are the questions you might be asked in the exam process if you do very well. So what is the evidence for open versus laparoscopic gastric? Yeah, it's laparoscopy. You need to have skillful surgeons to do, and it has to be done in a high volume center. And in the laparoscopy arm, satisfactory short term and long term compared to open. But this is exclusive to high volume centers. And if you try to reproduce this in the low volume center, I don't think the outcomes will be good. Staging laparoscopy, is it recommended? Yes, definitely recommended because it has changed the management in more than 60% of the population. Patients with gastric, resectable gastric sleeve. So definitely recommended in T3, T4 and N1 disease. But in our setting where we don't have access to PET-CT that freely, staging laparoscopy would be a better option. Again, can be done as a standalone or prior to the index surgery on the table. Okay. So lymphadenectomy, what is the evidence? As I told you, D2 dissection is the standard, and it has been clearly shown to be prognostically better. However, if it carries the pancreatic or splenectomy, the morbidity is going to be high. Right. So D3 lymphadenectomy is not necessary. Okay. So what are the reconstruction options? I showed you some slides regarding the reconstruction, but the optimal reconstruction should provide a functional reservoir as a neostomach, provide duodenojejunal continuity, and minimize functional disturbance. But if you do a rule and by reconstruction, the duodenal continuity is lost because it's a ruling the jejunum comes and joins later. Options 2-1Y esophagojejunostomy plus or minus a jejunal pouch, which we have done. Jejunocolonic interposition, that is in between the esophagus and the duodenum, you interpose a jejunum or colon. If you Google, you will find fancy names for these reconstructive options. And there is another thing called looped esophago-jejunal anastomy. Okay, so this is the preferred option now. 2-1Y esophagojejunostomy. It can be done retrocolic or anticolic, but the length should be at least 50 centimeters to prevent bile. Okay. Would you do a jejunal pouch or not? Which we have done. But it is often it's better in early post-operative period, but long term there is not much of a difference. But the patients that we have operated on, they usually give good, they have a good quality of life. That is not evidence-based, but that is what we have seen. But evidence-wise, esophagitis is less, dumping syndrome is again less, disturbance is also less. Bursectomy is not at all done now, and there is no evidence. Bursectomy is basically the resection of peritoneal lining in the stomach bed. Okay, and feeding jejunostomy is ERAS protocol doesn't suggest to put a feeding jejunostomy. But if patient is malnourished and if you think the patient would take a longer time for him to establish enteral feeding, better to put a jejunostomy. Okay. So thank you very much. Any questions? Have I covered the questions that you have had? So again, I was invited on a very short notice. Yesterday at 9 PM only I got the call. I was lucky my boss Chaturanga Kapitiagamasa was he helped me a lot to prepare the slides, so thanks to him. So thank you College of Surgeons for inviting me. Thank you very much for attending. Have a good day.